Hello, I'm Dr. John Kruse, and thank you for coming here today. Today's question and answer session will be focused on two videos, not focused, starting with launching pad for um, two videos that were released the past week, also any ADHD topics in general and mental health topics more broadly. I will be struggling to be coherent today because I am sleep deprived. I was traveling the last 2 days. I was not supposed to be traveling all those last 2 days, but got in after 2 a.m. to Newark Sunday night and then got into Rochester, New York after midnight last night. So if I'm not making sense, that is why. It's not just because we live in a world where not making sense can be important. The two videos that were released this past week were a new one on acetylcholine and ADHD, and an older one was Max did the sound for DNA testing for ADHD. Regarding DNA testing for ADHD, there are more than a dozen companies in the market claiming that they can tell either that support a diagnosis of ADHD through genetic testing or tell you which medications to take because of genetic testing. And while there is some real information obtainable from these tests, they are, I'd say, of extremely limited clinical utility for almost everyone. So part of it is that aside from a few people in some very unusual families, there are not a few strong genes that hugely increase your likelihood of having ADHD. ADHD tends to be polygenic, which means hundreds, if not thousands, of genes each have a tiny, tiny role. And in terms of medications, most of the systems out there are, one, looking at your genes, not looking at the epigenome. So even if they tell you you have a certain form of a gene that metabolizes this drug quickly or slowly, and that may cause problems or may help you get by with a lower dose, it doesn't tell you how many copies of that gene your cells in your brain are actually making. So unless we know how well turned on or off the good or bad or fast or quick versions of the gene are, the information is highly suspect as to whether it's useful. And two, just knowing that you have an enzyme, even if you know you have lots of copies of that chew up a drug really quickly, that doesn't mean you have to avoid a certain drug. It just means you may need a much bigger dose of that drug to get the same blood effects. So DNA testing, we may well have more useful, valuable clinical information in the future, but not at this time. And the second video that I released was on acetylcholine and ADHD. Kind of like when we talked about glutamate a few weeks back, the acetylcholine system is a much bigger numerically present system than dopamine, norepinephrine, serotonin, which get all the press. Those are each representing less than 1% of the neurons in the brain. Acetylcholine is much bigger, both in the brain and the periphery. And not that that makes it better or more important, but it's highly important, but it also makes it more challenging to study just because messing with it is going to interfere with lots of other things in the brain. There is a brand new drug for schizophrenia that was released in the US that works on the acetylcholine system called Cobenfy. It seems to be effective for schizophrenia. It seems particularly helpful for improving cognitive status. So it's being looked at for Alzheimer's, ADHD, other conditions where there are cognitive and executive function problems. Most of that data has not yet been published, but people are interested for that reason. And that's going to be renewing interest in the acetylcholine system. The other big ADHD connection with the acetylcholine system is the nicotine receptor. Nicotine is one of the two main subtypes of acetylcholine receptors. There has been a moderately consistent body of studies suggesting that nicotine receptor agonists can have some benefit for ADHD. None of those drugs have been brought to market for various reasons. So that's what I will say there. So, hello, Dennis. And Dennis starts off with a question. I don't think I have anything meaningful to say on it. He asks, why haven't pharmacologists developed a drug to prevent stimulant tolerance? And I'm not off the top of my head aware of any drug of any type where we've been able to avoid or evade the body's. I mean, so tolerance means giving the same drug, same dose, results in less and less impact, or putting it the other way, you need a bigger and bigger dose to get the same biological effects. So I'm trying to think of other categories, non-stimulants, where, certainly not with opioids, pain medicine. So part of it is, I would say, first, so far, Mother Nature and your body is smarter than your brain in terms of figuring out ways to evade or avoid or respond and adjust to giving the same constant medication. That's kind of a non-answer, but that's where I'll leave it for today. So hello, James Alexander again. James asks, in my clinical experience, is there anything that distinguishes your adult ADHD patients for whom just guanfacine or clonidine is enough to treat their symptoms? Do they tend to have less severe ADHD? Are they primarily of the hyperactive impulsive type? Do they disproportionately have less intensity jobs, etc.? So one is my answer there is going to be probably idiosyncratic to my practice and the group of people I've worked with and how I work with them. So I think one is that patients who have not previously been on any medication are more likely to be satisfied with guanfacine than with the stimulant. And by that, I mean, if someone's had good positive experience with Ritalin or Adderall or Vyvanse or any form of a stimulant activating medication, they're used to feeling that level of sort of immediate, I'm shifting gears, I'm now able to focus, I'm now able to attend. Guanfacine is much slower or more gradual. So for people who have not previously had any medication, this may be an acceptable, several weeks from now, a month from now, they may feel that their brain is working better and be happy with that. And I shouldn't use value judgments like better, but since so many people put it in exactly those terms, I will. So most of the people I'm working with who are on guanfacine with a activating medication, whether it's a stimulant or whether it's a non-stimulant like bupropion or duloxetine or atomoxetine. So I know there are some people who speculate that, so maybe this does represent a less severe end of the ADHD spectrum, that maybe people who are on a more severe are more likely to have experimented either officially through a prescribing doctor or unofficially through friends or other sources. I know there are some discussions about whether guanfacine is more helpful with inattentive rather than hyperactive impulsive, or less helpful in that realm. I'm less sure that I've seen clear-cut differences or that people can articulate them, or that given that impairments in some executive functions and influence how well other executive functions are working there. So Max is pointing out that Vyvanse, and in Britain, Vyvanse has been out for a while and it's called Elvance, but Vyvanse, so lis-dexmethamphetamine, so dextroamphetamine molecule linked to the lysine. Lysine needs to be cleaved because the prodrug is an inactive drug, inactive substance. You have to cleave the lysine away before it becomes active active dextroamphetamine, sorry. So anyway, Max is pointing out Vyvanse is coming to European countries with the newly approved generic Xurta, X-U-R-T-A. I don't know if that's how they pronounce it. What are some of your approaches for switching from long-acting methylphenidate to Vyvanse, like for dosages equivalency? So one, I should have given off my general warning that I'm not making any specific medication recommendations. So this is general information to use. So the two sort of general thumbnails, three rules. One is the claim, and I think there's so that I'll call these rules of thumbs. These are generalizations, are not completely valid in all situations. They may not have been even rigorously tested, but clinical experience, not just mine, but others, supports that these are general useful frameworks. One is when switching at all among different ADHD drugs, you should look at the total daily dosage. So if you're taking 10 milligrams of a short acting 3 times a day, then you're taking 30 milligrams. You're probably thinking in terms of the same drug. If you have a long acting form, you're probably going to be in the general ballpark of a total of 30 milligrams a day of that form. So again, total, if we're working with the same substance, but just different half-lives or delivery lives, keeping same milligram to milligram. 2 is converting between Ritalin, methylphenidate-based products and amphetamine-based products. And again, this is a crude approximation. Amphetamine's about twice as strong for the same effect as methylphenidate, so you need half the number of milligrams. So if you're on approximately 10 milligrams of Ritalin a day, the ballpark recommendation is you're likely to be aiming closer towards 5 milligrams of Adderall a day. So that's a gross oversimplification. It's not strongly embracing different left-handed and right-handed isomers or other factors. So with the Vyvanse, the other big thing to remember is that only about a third of the Vyvanse is dextroamphetamine. The other 2/3 are that lysine, that big inert amino acid. So with Vyvanse, 60 milligrams of Vyvanse is roughly equivalent to 20 milligrams of amphetamine-based products. So I think those would be the 3 rules. So again, one's approximate same daily dosage. 2, amphetamine is about twice as potent as methylphenidate. And when we're just saying twice as potent, I'd say there are many people who do not just potency effects, but do get more thorough and more effective results from amphetamine Adderall-based products. And then 3 is with Vyvanse, remembering that again, only about a third of the milligrammage for Vyvanse is active dextroamphetamine. So Max is pointing out again, so again, that the videos released this week were the acetylcholine and ADHD and DNA testing for ADHD, but any mental health question, we tend to focus on ADHD, but are what we are certainly fair game for today. So James Alexander asks about my male ADHD patients who have sexual side effects like low libido and erectile dysfunction from atomoxetine, guanfacine, and similar meds. What has helped alleviate such problems for them? So again, I use almost no atomoxetine or Strattera. Guanfacine, I use some, but it's often when people are. So I see sexual dysfunction much, much more with the serotonergic medication, the SSRIs specifically, which is part of why I use NRIs more often. So what I can say is it's been a very infrequent problem, and I do ask people about it. I think I do create an environment where people can freely talk or ask questions about it or bring it up, but it is something I do ask about. I do not see commonly lots of sexual side effect issues with the ADHD medication regimens that I have people on. I mean, actually, when it's SSRI induced, it's not usually primarily erectile dysfunction. Some of the tricyclics can cause that fairly often. It's more often libido issues. And the common way of restoring libido issues is often giving drugs that have strong norepinephrine and or dopamine promoting effects. So we know about 2/3 of people who have SSRI-induced libido problems, deficiencies, when they're put on bupropion or when they take a stimulant medication, that libido tends to get better. Not always, everyone's different. So that, I don't know, that might not be particularly helpful, but that's what I have to offer up there. So Dennis is asking, have I heard of TurXT by Turan Bioscience? It's a prodrug of xanomeline and trospium designed for once daily dosing. So I'm blanking because I'm not thinking sharply right now. It sounds like Cobenfy, but just by a different name. So Cobenfy, so these are both acetylcholine acting drugs. One is an acetylcholine blocking drug, that's a trospium, and the xanomeline is a promoting acetylcholine, binding to acetylcholine receptors primarily within the brain. The two together, because I hope I'm not saying this backwards or screwing it up, but I might be in my state today. You'd think that the two might cancel each other out and have no effect as they're working in differential directions. But the trouble, my brain is just not functioning that well. One is found more strongly in the periphery, one is more strongly in the brain. The trouble with either flooding the brain or the body too much with too much acetylcholine or blocking acetylcholine too thoroughly is the neuromuscular junctions and the parasympathetic nervous system both rely heavily on acetylcholine. So getting the right balance and not blocking it completely or not overactivating it too much is important. Yeah, I'm not articulating that very. So Cobenfy was approved in the US for treating schizophrenia, and there are older studies looking at xanomeline for dementia and other cognitive problems. Again, this is a drug that does seem to be helpful with some of the first rank symptoms, including delusions and hallucinations, but also more thoroughly than any other drugs that have been looked at, helping with some of the negative aspects of schizophrenia and some of the cognitive problems that are there in schizophrenia. So James Alexander said, other than breathing exercises, sorry, it's jumping around. Breathing exercises, what has helped your patients avoid waking up in the middle of the night and get back to sleep, even if they do so. So I'll sort of reiterate, I'm a big fan of cyclic sighing, both for helping people fall asleep and for helping them fall back asleep if they're awake in the middle of the night. I think that the good sleep hygiene regimens, one particularly in ADHD that's challenging, is having a regular bedtime. Two, making sure it's dark enough, making sure it's quiet enough, making sure it's not too warm. 4 or 5, somewhere in there, remembering that for almost everyone with sleep problems, they don't have problems with their sleep system. They have problems with their daytime arousal system not shutting off, not allowing a place for sleep. So almost anything you can do to chill out, relax, and not force yourself to sleep, but try to create the space so sleep can exist. So there are other breathing exercises, other counting exercises, other distracting or engaging your brain. For people without ADHD, where it's primarily anxiety, one of the most useful and well-studied tools from CBT is jotting things down. So you can tell your brain, okay, it's there on the paper. I'll look at it in the morning. I can renew my driver's license. I can do X, Y, Z errands today. I'm not going to solve them in my sleep. I'm not going to solve them by not sleeping. And I'm not going to forget it because I've written it down. So, and then really checking in the morning, because if you continually write things down but don't check it, then your brain knows, hey, he or she is just writing things down and they're not even going to look at this later. So I have to keep remembering and reminding them or keep fidgeting with it. I'd say that writing down technique I've seen be really helpful with pure anxiety. I'd say it tends to be less powerfully helpful with ADHD because the ADHD brain tends to be able to find 101 new things to think about, not just things that they're worrying about. And they may not even particularly be worrying. Their brain is just going. Paradoxically, so again, this is something to be done cautiously, given that stimulants and related medications, one of their most common side effects is to keep people awake. But there are many people with ADHD where a small dose of a stimulant or a activating drug at bedtime can be tremendously helpful. And it's helpful because rather than thoughts bounding around and not being able to be controlled, the person can sort of put them in little boxes and put them away and shut their mind down with stimulants. Again, not everyone, and it's usually a small dose. So thanks, Max. Max supplied the link for the Wellbutrin video. And Max is also forwarding a Reddit question, and I know he gave me a long involved one to look at, which I've misplaced in my travel logged brain state. So on Reddit channel, the Substantial Bunch asked, can personality disorders be cured? So I'd say we can cure hams. We don't cure too many people in mental health. We can help some people resolve some issues. We can keep symptoms under control with ADHD and with bipolar disorder and panic attacks through medications, also often with cognitive behavioral and other therapies. So more, I think, pointedly or more to the question, and there is a talk on personality disorders. I think we have a link to the New York, Manhattan ADHD group. I talked to them 2-3 weeks ago. And I also have separate videos on borderline personality disorder and narcissism and interaction. So the old claim was personality disorders were not biological. They were purely shaped by the training that your family, the harm they did to them, and that they were persistent throughout life and not very responsive to change. We now know that as our axis 1 primary problems like depression, schizophrenia, there is a substantial genetic contribution to who develops personality disorders. And there's growing evidence that certain traits or aspects of personality disorders can be modified or changed. Most of the evidence there is through different forms of psychotherapy rather than medications per se. So change is certainly possible, and I'd say it can be meaningful change. That's where I'd leave that. So Iman asks, is there a noticeable difference between guanfacine IR and ER other than their duration of action for treatment of ADHD? I'd say the other big one tends in the US to be their price, where the extended release forms, whether it's Intuniv that's been specifically approved for ADHD or whether it's even forms that are primarily there for blood pressure, that the extended release forms tend to be much more expensive. So regarding the duration of action, so the FDA has only approved Intuniv, the long extended release guanfacine for ADHD treatment, but there are as many studies, at least when I last looked, looking at immediate release forms as there are extended release forms, and the magnitude of difference in terms of benefits, the effect sizes seem to me completely comparable. So the big reason and rationale, so we also know guanfacine tends to be a drug that works indirectly. It's not its direct action on the alpha-2 receptors that's causing improvement in ADHD, because if that were the case, you would see improvement in minutes to hours. I've had 2 people at least who did feel the guanfacine helped them that quickly, but most people take several weeks. And with other mental health medications that work indirectly, it's not essential to have a completely steady state level of the drug in your blood all the time. So in contrast, if you're dealing with a seizure disorder, if you're dealing with an antibiotic recommendation, you want the blood level of the drug in your blood to be fairly constant and above whatever critical threshold all of the time, because we know if it drops too low, then the little microorganisms can multiply, or that you're prone to having a seizure. So with certain drugs, particularly if they have immediate direct action, it is important to get a steady state. For drugs that are indirectly causing benefits, and with our mental health drugs, it's usually we're messing with a certain neurotransmitter system, and that system, again, it's not the direct neurotransmission that's important, it's whatever that signal is conveying to the brain, and the brain is probably then making new proteins, changing how nerve cells synaptically connect with each other, growing new spines, sometimes even growing new nerve cells themselves, and some of the antidepressants seem to have that effect. Those are slow and indirect effects, and we know that as long as the brain is receiving a strong enough signal for enough hours a day, so that could be just once a day, it doesn't need to be screamed at 24/7 constantly for it to do it. So in terms of efficacy, similar effects. On the other hand, sedation from guanfacine does seem primarily to be a direct and immediate effect. And the claim or the hope or the thought was the extended release forms sort of smear out the level at any one time, and that minimizes the degree of sedation. My clinical experience, and there are certainly people who have broader experience than I do, is that what happens is that instead of the optimal situation is that you actually wind up with more daytime sedation than you do from an immediate release form, which is delivering most of the drug if you take it at bedtime at night. Again, the indirect effects are still working over the course of several days or weeks, day and night. And the sedation is much more restricted to the nighttime, where you would want any sedation to be. So I am a big fan of immediate release guanfacine for ADHD. I'm not aware of any direct head-to-head between the two of them to look at either side effect burden or efficacy, but that's what I would say. And again, I don't see a lot of other people with expertise promoting what I just said. But Windstorminator said, I noticed when I eat 4 eggs, I get very depressed. 4 eggs a day, I get very depressed. I've read about the choline hypothesis for depression, and now I eat 1 egg every couple of days. Any thoughts on this? I'm pretty sure it was you. I don't think there's lots of people were eating 4 eggs a day and then switched and then saw that they were feeling less depressed. Whether it's the choline in the eggs, I mean, there's lots of cholesterol that you're being delivered to, and there are certainly studies going back, when was I in training? 30 years ago, showing particularly, it's not a linear relationship, but cholesterol can have an effect on mood, and particularly abrupt changes. So it might have even been changing from 4 eggs a day to a few eggs a week, maybe an abrupt reduction in cholesterol that way rather than the acetylcholine. Other than that, I don't know what else to make of it. So that's, other than I guess something else was going on in your life that made you a change from a pattern over 15 years of taking lots of eggs every day to not. So maybe whatever else brought about or triggered those changes or was associated with it could also be having a mood effect. Max asks a good question and asks, are there any doctors, psychiatrists in movies or TV series that you feel make a good portrayal of the profession? So unfortunately, I don't watch a lot of television, so I don't have much to comment on, and my awareness of shows is often through reading reviews of them rather than watching it themselves. I know lots of people, Dr. Katz, I'm trying to remember. I've seen one episode after it was highly recommended. I'm not sure what the name of that's. So I'd say very often in movies, psychiatrists are particularly portrayed as being, spectacularly crazy themselves, or twisted or weird, or inefficient or ineffective. Those do fit with not just general stereotypes of psychiatrists in general population, but with stereotypes that exist within the field of medicine themselves. I think there's actually a kernel of truth to it. So my experience is that people who went into psychiatry were two general groups, either those who actually did have their act together and were quite intelligent and felt that this was the most interesting aspect of human life rather than just the plumbing and the machinery, and that this was the most impactful way to help people's lives and health. And then there is a group of people who either do have their own very prominent issues and or had intellectual or other challenges where it was harder in a more objective field like cardiology or radiology to your incompetency would be revealed more quickly. So I do think there's an overrepresentation in psychiatry with some of these oddball features, characters, and incompetence, but I don't think that's the majority at all. So I know, particularly in the last decade or so, there's a number of series that have tried to portray therapy, and I'm just surprised so often when I do see psychiatry. I mean, usually movies, psychiatrist is a bit role. I'm trying to remember which action movie I saw because my husband likes action movies. Where it had someone who was traumatized, and I think they were a former murderer or gang member, and then they were in therapy for treating some of those issues, and then the therapist broke all sorts of boundary violation, had poor boundaries with the patient, but showed that she was there in a meaningful way for the patient, and that had some curative effect. I mean, it seems at some level to be promoting crossing boundaries, which I think in general are there for good reasons and for the protection of patients and shouldn't be disregarded. I'll just leave it at that since I don't have specific content or comments that I can think of right now. So Max is putting in the link to the stimulants and cardiovascular risk effects. So James Alexander has a long question about viloxazine, Qelbree. So the question is sort of what is the mechanism of action of Qelbree? And again, Qelbree, when it came out more than 30 years ago and was used in Britain primarily, but I think in other European countries, it was advertised, this is a norepinephrine reuptake inhibitor. This is how it works. It worked as an antidepressant. It wasn't ever a particularly popular one, even though side effect profile tends to be pretty benign. I think partly being a class by itself. For marketing reasons, not again for it was causing rare problems. It was pulled from the market in Britain. It was used briefly for treating narcolepsy in the US, and then research, it was bought out by a different company. Research indicated it was helpful for ADHD. It did get approved for ADHD, and more neuroscience, neurochemical evaluations of what it's doing came out with its re-release as a ADHD medication. So part of what I'll sort of say is, so James Alexander's pointing out that some of the studies, or lots of the buzzword is that it's a serotonin 2B antagonist, so blocking that receptor, and yet the FDA summary suggests that it's having both promoting serotonin and antagonistic and agonistic activity, and some of the lab data showing that at 1 micromolar concentration, so a low concentration, it's acting on the serotonin 2B. And that it seems to be acting more strong. So one is how something works in the body can be differently than how something works in a mashed up preparation of ground up receptors and partial membranes. Two is that there can be species differences. So often the ICD, IC50 numbers and the pharmacokinetics are often done on non-human samples. And different labs can get different relative effects and absolute effects, given different, slightly different concentrations in buffers in the solution can affect how complex receptors, what shape they hold in a complicated mixture. And so I would not focus too strongly on the exact particulars, but looking, and also it's hard to know comparing one set of standards from one lab to another lab. What if they're looking at different receptors? They again may be looking in a different solution, a different environment where their numbers are valid but aren't comparable to another lab's groups. So I'd say looking within a lab, if a lab's doing multiple assays at the same time, is probably more meaningful. But again, whether those assay conditions are actually reflecting the conditions that the receptors are facing in the brain is an important one. So I would take all of that with a grain of salt, and I'd say right now we don't have a clear or compelling explanation at a molecular level for what calbriviloxacin is doing. It's probably, again, has some mild norepinephrine effects. It probably has some serotonin effects, and separate from the immediate effects any of these drugs have on receptors, all of these then have downstream effects and are interacting with each other. So okay, so I'm backed up. There are lots of questions. So I hope that was my attempt at answering that. Yep, so my friends have a lovely library. They are bibliophiles. Max's forwarding question on Reddit by Substantial Bunch again. It's clear that the prefrontal cortex is the part of the brain most involved in executive functioning, but what would be the second most important part? And he's putting money on the intercingulate cortex. And I'd say, yeah, I mean when we're talking circuits, and again, even our idea of a circuit is sort of so simplified and idealized that it's hard. I mean, we draw these nice little diagrams, but then we are omitting or sort of forgetting the fact that each neuron is probably getting input from several hundred, if not a few thousand other neurons. Some of them may be as part of the circuit, but a lot of them are other input, and we boil things down and simplify it. And these are, I'd say there's a kernel of truth in our good models and less than that in the bad models. So James Alexander asks, why do amphetamines tend to work so much better than methylphenidate and the non-stimulants? Is it simply that amphetamines increase dopamine, norepinephrine, serotonin more than methylphenidate? Qelbree, the alpha antagonist, also more than, and also more broadly across the brain than Strattera does. And asking whether it's impossible for pharmaceutical companies to create compounds that exceed amphetamines in efficacy for treating ADHD as monotherapies. So one is that most of the ways these drugs are boosting, particularly norepinephrine and dopamine, and we won't get into, some drugs are more strongly acting on one or the other. Methylphenidate is primarily a reuptake inhibitor, probably atomoxetine, primarily a norepinephrine reuptake inhibitor. Qelbree, maybe less clear. The tricyclics are primarily reuptake inhibitors. The SSRIs tend not to be helpful for ADHD, but the SNRIs tend to be. So again, most of these are working through reuptake inhibition. So the signaling neuron releases norepinephrine and dopamine. It diffuses across the synaptic cleft. That binds to receptors on the receiving neuron. And for a signal to be meaningful, it has to be turned off as well. Those molecules are diffusing on and off those receptors, sending a signal there. And much of the turnoff is by the amount that's diffusing back to the original sending neuron. There are receptors there which are retaking it back up into the cell, so it's not able to diffuse around in the synaptic cleft, on and off receptors. But what amphetamine is doing, in addition to being a reuptake inhibitor, is actually it's increasing the amount of release from the vesicles when they bind there. So it is really, so you could argue that a reuptake inhibitor isn't giving you a bigger boost, it's giving you a longer boost. Whereas the amphetamines are releasing more, are causing vesicular release of a greater quantity. So I think that's most of why it feels like more. You are doing more. You are getting a bigger dopamine and or norepinephrine hit. I mean, whether they can boost it, I mean, part of it is the more you boost that hit, probably the more you increase potential for addiction. So methamphetamine, which is a legally sold, at least in the US, drug, also does seem to have higher potential. And I do have a video on meth is not amphetamine. They are different substances, but methamphetamine probably causes proportionally even a greater excess boost. So you could argue we already have one drug, but it's used very cautiously by most of us, again, because pretty clearly that greater dopamine boost seems to increase the likelihood of both, I would argue, psychotic reactions and addiction potential. So the finisher is endorsing cyclic sighing. Yes, 3DR is getting back to how to measure, how would you even measure improvement? Yes, we have scales, but they tend to be highly subjective. And I mean, I think there's enough psychological research, though, that again suggests there's some kernel of validity, and that many of our testings for personality do, I mean, one are valid, consistent test taker, or consistent from administrator to administrator of the test, and do seem to have some correlation with real life distress or performance. So I don't think they're all garbage, but yes, they are crude. Max asks, should stimulants be accompanied with eating more food and or adding a breakfast because the body is using up more energy than it's used to, or could undereating cause tolerance issues like brain fog? So a lot of different questions embedded in there. I mean, one to begin with, and this is not necessarily the case 40, 50 years ago, but in our modern world, where lots of people are overweight, the proportion of overweight people with ADHD is higher than the general population. So stimulants also can have appetite suppressant. I'd say the most common problem I still run into is not what how the drugs are functioning or not, but that someone's lost their appetite and is losing weight more than they'd want to. So for people who have trouble with appetite, usually taking food or having a meal before or with their stimulant tends to help, because that's when the drug is lowest in their body and less impeding appetite. For the majority of people, appetite suppression diminishes with time pretty substantially, but some subset of people do have it as a persistent effect. And it's not even clear whether with stimulants, whether the brain is using more energy than it's used to. So there are some, I mean, it depends a lot on what testing conditions, but there's some functional MRI research which suggests that for at least some set of tasks, the ADHD brain is overactivated. Pathways that normally would be shut off or inhibited are still working. And that, I think, makes sense in terms of the feel that too much is going on, too much is being distracted externally and internally. And that part of what can happen with stimulants is that we're using the brain more efficiently. And again, the brain is a major consumer of glucose, energy, calories in the brain. So it's possible that an individual is using less energy on stimulants because their brain is working more efficiently. I haven't seen much speculation as to whether undereating causes tolerance issues or contributes to brain fog. I'd say the bottom line I would recommend is, particularly given that for most people, most effective stimulants are fairly direct and immediately, is to do your own experiments. If you're worried that taking it with food or taking it on an empty stomach is causing brain fog, then next week, try it 3 days with food and 3 days without, or try the food 2 hours after the meal, or try the food 2 hours before. So play around, but try to take good notes as to how your brain is responding, and also, as to the extent you can, try to find objective measures for how well your brain is feeling, because yes, if you don't normally feel brain foggy and you're feeling brain foggy, that may be clear and robust enough. But if you're always feeling some amount of brain fogginess, that may not be a very useful guide unless you have a way to quantitate it. And more often, if you can sort of quantitate, I can focus on my reading for 45 minutes, and usually I can only do it for 10. That gives you a measure that might be more useful. So James Alexander is asking about Parkinsonism and ADHD, and I do have a video on Parkinsonism and ADHD. So he's wondering whether I put stock in the idea that stimulant medications may increase ADHD patients' risk for Parkinson's disease by elevating the levels of extracellular dopamine and imposing greater oxidative stress on dopamine neurons in the substantia nigra due to more dopamine being oxidized and releasing free oxygen species lethal to cells. So thanks, Max. Max has provided the link to the Parkinson's video. One is the studies. I mean, we only have a handful of studies suggesting an increased risk of Parkinson's. Two is, except in a few isolated cases, like when we poisoned marijuana, sprayed it with the pesticide paraquat, and some of that got high doses of that were in certain supplies, and people at a very young age developed Parkinsonism. Most of the time, we don't know why one brain is vulnerable and develops Parkinsonism and not others. So in the absence of greater, I mean, yes, to me, it's plausible that having too much dopamine around, given that when too much dopamine is around, part of what can happen is oxidative species, which are highly reactive and causing cellular damage. That sounds plausible, but plausibility and truth have a very loose relationship. We have true things that are implausible. We have implausible things that aren't true. So there. So Iman asks, is there any SNRI that works better than atomoxetine for improvement of attention? So I would recommend, I have a video on Strattera. I haven't made one on duloxetine. My take is that duloxetine works as well as Strattera for ADHD. Now, they're roughly equally good norepinephrine reuptake inhibitors. Most people can tolerate a functional dose of Cymbalta immediately and can get started right away. Most people need to start really low on atomoxetine. It is possible that some part of the benefit for atomoxetine for ADHD is slow and cumulative as well, and due to glutamate systems, whether duloxetine also has those effects on glutamate systems. I'm not aware of any research showing plus or minus. So I think and part of it is that Eli Lilly was the maker of both Strattera, and they didn't want to cannibalize their Cymbalta sales by saying, oh, Cymbalta suddenly is not just good for depression and anxiety and chronic pain, it's also an ADHD medication. So I think there are other agents with norepinephrine reuptake action that are as good as atomoxetine, but I don't know of any head-to-head studies. So I don't even know what ADGD, ADD. I'm going to try to Google it quickly. So attention deficit genealogy disorder. So I can't answer what ADGD, ADD. I mean, I would say, and part of what I speak about is that we like to focus on the biological variables for ADHD because to some extent that helped to legitimize it as a real condition. But very clearly as Dr. Barkley also pointed out in response to the New York Times, Paul Tuff, I think was his name, article that got lots of publicity. We've known from the beginning that there are psychological factors which influence which brains develop into ADHD brains. So amitriptyline or Elavil is one of the drugs that it's a tricyclic antidepressant. There's evidence that it and other tricyclics are effective for ADHD, and their efficacy, again, is comparable to Strattera, comparable to other non-amphetamine So I'm not a big fan of Elavil at all. So the tricyclics and I have talked about this. I don't know if I have a video just on tricyclics. I'm trying to remember where it would be. Tricyclics are horrible drugs in lots of ways. because they have lots and lots of side effects. Most people gain weight, most people are constipated, and amitriptyline is pretty strong on both of those. They can cause cardiac irregularities, arrhythmias that can be lethal. This is why they were dangerous in overdose. So if you're trying to get someone, help them primarily with norepinephrine reuptake or serotonin and norepinephrine reuptake, I think the SNRIs are much cleaner drugs. And I'm not aware of any. I mean, if you want to be sedated, if you want to have orthostatic hypotension, so blood pressure drops and you stand up quickly, then take the tricyclics. And yes, at lower doses, many people avoid many of those symptoms, but just intrinsically, they are messier, less, to me, desirable drugs to have around. So. Yep. So James Alexander is following up on the, so again, when we're focused on one study, I wouldn't read too much into it. If we get lots of studies showing the same pattern, then I'd be more concerned. But the university study found that those with ADHD had 2.5 times greater risk for developing Parkinson's. And among ADHD patients taking methylphenidate, they had an 8 times greater risk than those taking it, whereas anyone on any stimulant just had a 6 times greater risk. Now, this would suggest, since the any stimulant group had both ADHD, had both methylphenidate and amphetamine populations in them, you would think if it was purely dopamine availability, then the methylphenidate group would have a lower risk. So a couple issues then. Again, this is an observational study. This is not a random controlled study. So which ADHD patients wound up with no drugs, which wound up only on Ritalin, which wound up on Ritalin and or an amphetamine-based product are not probably likely to be exactly the same populations of ADHD individuals. So it could be severity of the condition was milder in one group than the other, responsivity, so that the native starting out dopamine environment in the brain was probably different. So unless we're actually in this type of study where we're not randomly controlling and sorting people, if they had actually provided some measure of what's going on in the brain related to dopamine, that would be interesting. But other than, just that different groups had different rates of developing Parkinson's, there's too many potentially confounding factors. So that's what I would say. So I wouldn't say that this single study disproves that it could be, again, excess dopamine and dopamine causing free radical damage. Hello, Tom asks about guanfacine extended release. How should someone know if the dose they're taking is causing normal sedation and fatigue or too much depression? So what I would say there is, again, the time course is different. So the side effects tend to be immediate and direct from what I've seen and what most people seem to report. The benefits seem to be slow and indirect. So if you're worried, is this product causing me too much sedation? You could skip it for a day and see, is the next 24 hours different in terms of fatigue level, sedation, or is it pretty much the same? Again, skipping it for a day, particularly if it's several weeks into treatment, probably is not going to reverse the overall benefits or interfere with the developing benefits. I mean, early on, and this is by analogy to antidepressants, which antidepressants tend to work slowly and indirectly, but we tell people early on, absolutely take it as consistently as you can. And there's very good evidence, and it's pretty robust from multiple drugs, multiple situations, multiple years, the more consistently you take the drug, the antidepressant to begin with, the higher the likelihood you will get a response and the somewhat quicker response. So with an indirect signaling system, giving a strong enough signal consistently enough is really important. You don't want to confuse the brain into whether it wants to gear up to make those proteins, to make those new synaptic connections. But once it's up and going, skipping for a day or two doesn't seem to disrupt that process, but again, should reveal what I'm feeling today, primarily from the guanfacine I'm taking in the last 24 hours or not. Yes, D3R is suggesting that most neurological diseases have been linked to carnivorism, and then cites prion diseases. I'd say most neurologists currently would say prion diseases are an extremely tiny percentage of neurologic problems, and that we have some neurologic diseases like Huntington's that are clearly strongly genetically caused. We have environmental toxins like mercury or others that can cause neurologic diseases. I would question that most neurologic diseases or disease has been linked to carnivorism. Some have. Blue Basset, and I'm realizing it's an hour, so I'm going to try to wrap things up. Is there any medication particularly effective for brain fog? I'm on Adderall. It helps a lot with focus, but my brain still feels like it's on the low level of fog much of the time. So as 3D, brain fog is poorly defined, and it's a subjective feeling of feeling cloudy, sedated, not able to think clearly. There are not a lot of rigorous formal studies that either define it or look at what's effective, but many of the clinics, particularly post-COVID clinics that are dealing with many people with brain fog, are using many of the ADHD medications. So I do have a video on brain fog, which Max found a link for. Thanks. So there seems to be a lot of individual variability. There seems to be a very strong connection with brain inflammation and brain fog. So stimulants may be sort of countering it, but not treating it at the source as it would. And there's maybe more evidence that things like guanfacine, which actually can be sedating, but might have some anti-inflammatory and prefrontal cortical strengthening factors may be helpful in the long run as well. So James Alexander asks, do I think that ADHD-related perfectionism causes some patients with significant symptoms to deny condition and delay going in for an evaluation or getting treatment due to having thoughts like, I can't possibly have an inherent imperfection like that, or I can't have a condition that requires me to take meds like stimulants? Yeah, so I think perfectionism is one of many factors. I think more often there's stigma and unawareness of what ADHD can entail. I'd say there's a whole host of reasons, but I could certainly see or believe perfectionism, and I'd say some of what you're saying is almost suggesting narcissism as well as perfectionism. In terms of I can't possibly have a flaw, I would say is more classically narcissistic than perfectionistic. There's a lot of overlap, but so Iman again asks, which bipolar medication is least likely to worsen ADHD symptoms, particularly attention? What we classify as a bipolar medication is a pretty broad term, but I'd say I would be particularly interested or thinking particularly if someone came to me with both conditions, that Abilify which again is not just a dopamine booster or a restrictor, it's a dopamine modulator. There's some evidence that is helpful in ADHD, and there's a lot of evidence that can be helpful as a mood stabilizer. So that would, and I have a talk, I think it's on antipsychotics and ADHD where I mention that, even though it's here in the context of an antibipolar medication. Hello, Larry. So thanks for showing up. So Blue Bassett is talking about, I would say, troubles with working memory, keeping things in mind long enough to make use of them. So again, that can be one component of brain fog, but I'd say there certainly are people who clearly have severe impairment of working memory where that's a specific deficit and don't particularly feel brain foggy or clouded. They're just, they would say, really forgetful. So Tom expresses feeling a surge of motivation for a few hours. So again, I might have not made this clear. When I prescribe guanfacine for ADHD, I almost always use extended release, and I almost always treat it all right at bedtime. So again, that's to minimize sedation. And from everything I have seen, the benefits from guanfacine are indirect and should not matter when someone's getting it. So yes, D3R is asking about, have I heard of Gene Gendlin and his focus research around first-person experiences? It's not ringing a bell, so sorry there. So James Alexander is asking, do I think the word recall difficulties and memory loss that people report for guanfacine and bupropion in the comment section of your videos on them and elsewhere on the internet have to do with their anticholinergic effects? Wellbutrin is generally known to be anticholinergic, while guanfacine affects to a lesser degree the same presynaptic receptors. It's possible. I mean, I would say more often people report feeling sharper on Wellbutrin than they feel. I mean, there are formal studies looking at it, particularly because the tricyclics clearly impair cognition and some executive functioning, but cognition aspects. The SSRIs, some people again do feel cloudy on them, but cognitive deficits were less common compared to tricyclics, but Wellbutrin tended to have lower. This is in a depressed population. So I'm clearly, lots of people can respond in ways that are atypical for the general group, but there may be specific unexplored reasons for that. So Max is thanking everyone for coming and asking them to check out the Reddit page where hopefully we can get longer. So I'll throw in one last question. So Sliman is asking, how is your patient's quality of life? Are any long-term benefits from medication? So I had a colleague 30 years ago who started one of the first therapist groups not therapists, psychiatrists specializing in treating ADHD, who, this was again when ADHD in adults was barely recognized, reported that it was one of the most rewarding treatments because many people respond quickly, and that not only has immediate benefits both on potentially focus, concentration, cognitive and executive functions, but on mood and other life factors. And I've certainly seen people who have substantially turned their life around from being on medications. Have I seen others who feel that they're thinking more clearly and feel they've made some better decisions and life is progressing well, but maybe it was generally okay to begin with. Yes. I've certainly seen other people where I'm not as clear there was a dramatic departure, but who felt that their impulsivity or other ADHD symptoms put them at such risk for derailment. So part of all this is hard to sort out psychotherapy along with medications, because the shortest visit I do with people is a half-hour visit. I don't do any such thing as a med check. I'm always talking with people, whether there's benefits there that are separate or intertwined with it. So there. So thanks for showing up. Thanks for being here. Stay healthy, stay happy in this moderately crazy world. And I will be back next week. Hopefully I'll be more rested.